Good afternoon, everyone. I am Dr. Bharat, Assistant Professor in the Department of Emergency Medicine. On behalf of the entire department, it gives me immense pleasure to welcome you all for today's clinical combined rounds. We would like to share an intriguing case that we encountered at the trauma center. It was a young male who presented with a blunt force injury but had sharp consequences. So we received a young male who presented with a blunt force injury but had sharp consequences. So we will discuss about the challenges that we faced in managing this patient and how we went about it. Joining me are Dr. Mehul and Dr. Archana, who are senior residents in our department. Dr. Mehul will be discussing the case and Dr. Archana will be taking us through the discussion part. I now invite Dr. Mehul to take us through.
Thank you, sir. We'll start with the case. The initial presentation was of a 32-year-old gentleman who presented with history of road traffic crash, two-wheeler versus four-wheeler. Basically, he was a helmeted rider who was hit from behind by a four-wheeler. Initially, the patient was actually treated at an outside hospital, and he was given treatment outside and eventually arrived at our center 27 hours after the initial presentation. So on arrival, we initially took a missed history that includes mechanism of injury, injury sustained, symptoms of the patient, and treatment given outside. So mechanism was two-wheeler versus four-wheeler. Injury sustained was he sustained multiple injuries over the extremities. Symptoms, he presented with chest and abdominal pain, and treatment given outside, suturing and limb immobilization was done in an outside hospital. So we then proceeded with a primary survey. Airway was patent and cervical spine was stabilized. On the breathing part, it was significant for chest compression test, which was positive on both sides. Circulation part, patient was hemodynamically stable, but fast was found to be positive in hepatorenal, sphenorenal, and pelvic cavities. Disability part was normal, and exposure part was also normal. Now coming to EFAST exam, subsequent views showed no fluid around the heart, but hepatorenal pouch, sphenorenal pouch, and the pelvic cavity also showed anechoic fluid collections. Adjuncts to primary survey was done. Success rate and pelvic X-ray. Success rate was significant for right, second, and third rib fractures, but there was no evidence of any pneumothorax or hemothorax. Pelvic X-ray was within normal limits. So after primary survey, we proceeded with the secondary survey, and ample history was done, but was non-contributory. Then we proceeded with a detailed head-to-toe examination, which is significant for swelling and tenderness over the right elbow. There was a degloving injury over the right little finger with tendons exposed, and there was a sutured wound over the right anterior leg of approximate 7 centimeter length. X-rays were done, and these was significant for a right ulnar shaft fracture, which is associated with radial head dislocation, right little finger proximal phalanx fracture, and right fibula shaft fracture. Now, as part of the secondary survey, we also did a point of care ultrasound guided secondary survey in view of the chest pain for the patient. And so we did a bedside echo. And this is the parasternal long axis view, and where you can see that there is an echogenic lesion within the right ventricle, as labeled in the figure here. This is the same in the parasternal long axis view, but a little bit more zoomed in, and you can again see the echogenic right ventricular lesion. We also took a parasternal short axis view at the level of the aortic valve, and we can see the right atrium, right ventricle, and again we see the mobile echogenic lesion within the right ventricle. So basically we had a 2 into 2 centimeter approximate size echogenic lesion within the right ventricle, which is mobile. So the differential diagnosis for such a lesion could be a thrombus, a cardiac tumor, or a vegetation. Now, thrombus is usually mobile, heterogeneous with irregular borders, and often classically described to have a serpentine or snake-like appearance. Tumor is not as mobile as a thrombus, and it is more common on the left side compared to the right side. And vegetations are usually much more closely related to the valve than it is seen in this particular case. So further investigations were done in view of the suspected RV thrombus. An ECG was done, which showed sinus tachycardia without any HTT changes. Troponins were done, and they are positive at 10.05 nanogram per ml. And bilateral DVT scan was also done to look for any source of the thrombus, and this was negative. Now, in this particular case, we consider possible reason for the right ventricular thrombus, which could be either a blunt injury to the chest because he's having chest trauma, which led to injury to the right ventricle, leading to chases of blood and eventual thrombus formation. And another possibility was the patient was having some underlying thrombophilia, which is never diagnosed, and this was the index presentation of the same. But considering that the patient is having acute symptoms with tachycardia and elevated troponins, we consider that this likely is due to a blunt injury to the chest. Now, at this point, we proceeded with CT imaging, and I would like to call upon Dr. Monica from the Department of Radiology. She's a senior resident to explain the CT imaging findings.
So now we'll be discussing the CT findings. So here in this presentation, we are showing the axial, the coronal, and the sagittal section here. So as we could see here, there is a filling defect. So that correspond to the RV thrombus. Here on the coronal section, we could again see a filling defect. And as we could see clearly on the sagittal views, that this filling defect is seen entering into the RVOT as well. So this slide here shows the hemothorax. So it is more so on the right side as compared to the left side. This shows liver laceration, predominantly involving segment 5 and segment 8. Now, here we could see some hyperdense areas corresponding to the lung contusion and the surgical emphysema.
State like the elevated D dimer as well as the decreased protein C and antithrombin levels. So to summarize our case, we have a 32-year-old male patient presenting with a history of road traffic crash, two-wheeler versus four-wheeler. He is on evaluation being found to have bilateral hemothorax, grade 3 liver injury with mild hemoperitoneum as well as multiple limb fractures. And he is also discovered to have a right ventricular thrombus with positive troponins. So the treatment dilemma in this particular case is that we have to balance the risk of further propagation of the RV thrombus and versus the risk of bleeding due to the hemothorax as well as the grade 3 liver injury. So in order to do this, we went for a multidisciplinary approach involving multiple departments, including Department of Emergency Medicine, trauma surgery, as well as cardiology. In terms of initial resuscitation, our right-sided chest tube was inserted for the hemothorax on the right side. It was more on the right side. Grade 3 liver injury was initially managed conservatively because the patient was hemodynamically stable. And for the RV thrombus, we started the patient on unfractionated heparin. Now, I would like to call upon Dr. Zenith, senior resident in the Department of Trauma Surgery, to describe the inpatient course of this patient.
So the patient was admitted under trauma surgery. So as is the norm, we always repeat our primary, secondary and the tertiary survey. So on consolidating the injuries, he had nasal bone fracture, a PSM mandible fracture of the outer alveolar rim, which was non-operatively managed subsequently. He had a blunt trauma chest with bilateral rib fractures, right more than left side hemopneumothorax, lung contusions predominantly on the left side as was discussed, sternal body undisplaced fracture, pneumomediastinum and a right ventricular thrombus. That was managed non-operatively by inserting a right side intercostal drainage tube. Blunt trauma abdomen in the form of grade 3 liver injury with mild hemoperitoneum. Upper limb extremity, there was a right ulnar shaft fracture and a right fifth finger proximal phalanx fracture with a degloving laceration there, which was initially operative. Lower extremity injury in the form of a right fibula fracture. So it was a patient of polytrauma with the ISS score of 34. Now during the progress, so as far as the right ventricular thrombus was concerned, so it was top eye was elevated. So we were of the suspicion that it is a traumatic blunt cardiac injury. So we discussed this case in our radiocon also. We took a cardiology opinion also, in which a 2D echo was done. There was no regional wall motion abnormality or akinesia. The LV function was preserved. So we started the patient on UFH infusion targeting a APTT of between 60 to 90, which was subsequently overlapped with warfarin, and warfarin was finally fixed at 3 mg alternate day, keeping the INR between 2 to 3. On the day 3, the patient developed some amount of dyspnea. So since we were keeping a high degree of suspicion in this patient, we did a CT pulmonary angio to see and rule out any incidence of pulmonary thromboembolism. However, finding it to be normal, and the right ventricular thrombus was still found to be persistent. The patient was subsequently, the ICD was repositioned, and after the drainage became less and less, it was finally removed on day 8. Ortho opinion, which was initially in favor of operating it for fixation of the ulna, was deferred in view of the right ventricular thrombus and the beginning of the anticoagulation, which was very important for this patient. So it was subsequently changed to a conservative management and done with a POP cast. There was also a right little finger proximal phalanx which degloving injury, which subsequently went into dry gangrene, and patient was kept on follow. Patient was discharged on oral antibiotics, analgesics, warfarin, spirometry, physiotherapy, and steam inhalation for the chest trauma. On follow-up, a repeat 2D echo was done after 6 weeks, in which no thrombus was found.
Thank you, sir. So to summarize, after a multidisciplinary discussion, it was decided to continue with a conservative approach to the RV thrombus. Patient was overlapped with warfarin and later discharged on warfarin, and the orthopedic fractures were managed conservatively. And on follow-up, the thrombus resolved after 6 weeks of therapy. Now I would like to call upon Dr. Archana to continue with the discussion part.
Thank you, Dr. Mehul. So, continuing with the discussion part, initial resuscitation and stabilization of trauma patients we do in the trauma AD. And when there is a blunt chest trauma and the patient is hemodynamically stable, we opt for observation. And if the patient is unstable, we proceed for operation intervention. And blunt abdominal trauma, if the patient is hemodynamically stable, it is observation versus angioembolization. If the patient is unstable, patient will directly proceed to the operating room. So in a polytrauma patient, when there are bleeding manifestations, that is features of hypocoagulability, and there are clotting manifestations, that is hypercoagulability. As in this patient, he had both liver injury associated with hemothorax and hemoperitoneum, and clotting manifestation as in there was an RV thrombus. This is where we have to discuss about an entity called trauma-induced coagulopathy or TIC. So coming to the trauma-induced coagulopathy, it is hypocoagulability and hypercoagulability. There are two phenotypes. So there can be hyperfibrinolysis, platelet dysfunction, fibrinogen depletion, or decreased thrombin, all which lead to hypocoagulability. That is, it will all lead to bleeding phenotypes. Whereas increased thrombin, hyperfibrinogenemia, platelet activation, and decreased fibrinolysis, all this will lead to clotting phenomena, that is thrombotic phenomena. In trauma, there can be both bleeding phenotypes and thrombotic phenotypes. And sometimes, rarely, there can be mixed phenotypes where the treatment is very challenging because of the balancing the risk of hypo and hypercoagulability. So coming in detail about the pathophysiology of TIC, all what is given in blue here is pointing towards bleeding, and all given in yellow is pointing towards clotting. So TIC is a complex interplay between hypoperfusion and tissue injury, which will activate the immune system, endothelial system, and the platelet system. So this activation will cause the central hub. So this central hub is the main part, and here is a vicious cycle. And because of this, there will be release of separate plasminogen to plasmin and help in fibrinolysis or clot dissolution. So all these factors will proceed towards the bleeding risk. Whereas factor 5, fibrinogen, fibrin, and thrombin, which can help in the conversion of fibrinogen to fibrin, and alpha 2 antiplasmin and plasminogen activator inhibitor, which will inhibit the fibrinolysis. All this will move towards the clotting phenomena. Hence, we can see here it is a very complex pathophysiology where there is both bleeding phenotype and clotting risk. So, coming to TIC, early hours, likely in less than 6 hours, it is hypocoagulable state and where there is a risk of hemorrhage. And in the later hours, where it is more than 24 hours, there is hypercoagulable state where there is a risk of thromboembolism. So, in trauma, we commonly encounter bleeding manifestation, but the risk of thromboembolism is not uncommon. Incidence can be varying from 0.35 to 24%. And the determinants of post-traumatic venous thromboembolism is the virtuous triad that include hypercoagulability, stasis, endothelial injury, and also acute inflammation. So DVT and PE are anticipated consequences of trauma, where in this case it formed the thrombus from right in the heart. So coming to right heart thrombi, floating right heart thrombi is a rare phenomenon. Usually it is seen in patients with suspected or proven PE. The origin can be either from a systemic vein or it can form de novo within the cardiac chambers itself, as in this case. So right heart thrombi with pulmonary embolism is common. Among this, it is common 98%, which has a poor prognosis, whereas without pulmonary embolism is 2%. Our patient fell into this 2% category without pulmonary embolism. So it is a time-sensitive emergency, and the retrospective studies have shown mortality in the first 24 hours can range from 21 to 60%. And without treatment, it can be as close as 100% mortality. So the treatment dilemma is there is no higher level of evidence, and retrospective analysis of cases and case reports and case series are only available here. So we did some literature search to see cases of trauma with both thrombus and bleeding manifestation. Most of the cases we found were of IVC thrombus associated with liver injury in trauma patients. A case from Tunisia in 2017, this was an 18-year-old male with short road traffic injury who had liver injury and IVC thrombus 13 hours post-trauma. This patient was managed with the UFH and IVC filter was not placed because, as mentioned, it was in some unusual location of the thrombus. In 2017, another case was reported. A 17-year-old female with high-speed road traffic crash with multiple solid organ injuries, grade 5 liver injury, right adrenal hematoma, grade 4 right kidney injury, moderate hemoperitoneum, rib fractures and lung conditions. This patient also had IVC thrombus with extension to right atrium. This also was managed with anticoagulation. In 2021, two cases were reported from Japan. That was one was a young female with a grade 1 liver injury and IVC thrombus developed after 1 week. There was an additional risk factor for this patient. The patient was on oral contraceptive pills. And there was a 58-year-old male with grade 1 liver injury, subarachnoid hemorrhage, facial bone fracture, right hemothorax, multiple rib fractures, and patient had hepatic artery aneurysm and thrombus. They opted for embolization for the aneurysm and IVC filter and anticoagulation. So these are some published reports of IVC thrombus complicated by traumatic liver injury. What we have to focus here is the treatment, where we can see anticoagulation and thrombectomy were the main modalities opted by all of these patients, by all of these centers. Then we did further literature search to see for trauma with cardiac thrombus and bleeding. It was further less in number. So there was one report where there was an RA thrombus post-trauma, where there was a patent for ananobale for this patient, and there was subarachnoid hemorrhage, which was a contraindication for anticoagulation. Hence, they did a catheter-directed therapy, that was the flow retriever thrombus aspiration. And in 2017, another case was reported where clot extended from IVC to RA to RB, 18 hours post-trauma, and was associated with pulmonary embolism. Again, management was IVC filter and anticoagulation. And another case was RV thrombus following penetrating trauma to epigastrium. The patient initially did not have any thrombus, laparotomy and thoracotomy was performed, and there was an RV injury which was sutured and later a thrombus developed, which was also managed conservatively. There was a 4-year-old girl's case reported in child abuse. There was an RA thrombus which was also managed with heparin therapy. And in 2024, there was another case, 19-year-old female who sustained a high-speed road traffic crash with pericardial effusion, and in view of imminent cardiopulmonary arrest, thoracotomy was performed. There was a lactation at the junction of RA and SVC, which was sutured. And post-injury day 6, there was a clotting thrombus, which was also managed with anticoagulation. So, what are the risks associated with this thrombus? RV thrombus can cause pulmonary embolism. LV thrombus can cause systemic embolization. Atrial appendages, any thrombus can lead to thromboembolism, and any intracavitary mass has a propensity to cause obstructive shock and embolism. So management principle, it is always a multidisciplinary approach. Right heart thrombus, the treatment options are therapeutic anticoagulation alone, surgical thrombectomy, catheter-directed therapy, and thrombolysis. Thrombolysis is very rarely or almost contraindicated in trauma scenarios unless a very extreme situation like the patient is in peri-arrest condition. Catheter-directed therapy also has a risk of embolization. So anticoagulation is considered when the patient is hemodynamically stable, when there is a mobile or free-floating RV thrombus, when there is confirmed or concurrent PE, presence of DVT or any other evidence of venous thromboembolism, and the traumatic injuries are stabilized without any active bleeding. And if the surgical intervention is delayed, planned delayed, where the thrombus burden reduction is the first choice. If there is very active bleeding, recent neurosurgery or traumatic brain injury, uncontrolled solid organ injury with active bleeding, severe thrombocytopenia, or need for any urgent surgical procedure or a spinal trauma where there is a risk of epidural hematoma, anticoagulation is not indicated. Surgical thrombectomy is done for mobile large RV thrombus when the patient is in hemodynamic instability or failure of non-responsiveness to anticoagulation, or if there is a coexisting cardiac injury which requires surgical repair. When the patient, it is not indicated when the patient is not expected to survive due to unsurvivable polytrauma or some advanced brain injury, if there is severe multi-system instability due to the lethal triad, and if there is a lack of surgical expertise or if there is a DNI-DNA status, we don't prefer surgical thrombectomy. Coming to catheter-directed therapy, the patient is hemodynamically unstable with high clot burden if there is free-floating or mobile thrombus, and if there is no immediate access to surgical thrombectomy, or there is a failure of anticoagulation with a persisting or worsening clinical status, we may consider this, but there is the risk of embolization. When the patient is having severe coagulopathy, uncorrected coagulopathy, lack of technical expertise, non-compressible vascular style access, then it is better not to go for catheter-directed therapy. Systemic thrombolysis, as already described, is almost contraindicated or not performed in any scenario unless the patient is in hemodynamic instability like peri-arrest or an arrest condition with massive, confirmed massive PE or an RV thrombus. And contraindications are same as in any systemic thrombolysis like recent intracranial hemorrhage, structural cerebral vascular lesion or an intracranial space superfine lesion, recent ischemic stroke, suspected aortic dissection, active bleeding, any close to head facial trauma, or recent intracranial surgery. All these are absolute contraindications where we should not even think of thrombolysis. Coming to IVC filter, our patient, the thrombus was already in the RV, so there was no much role of an IVC filter. Whereas it can be considered in DVT where there are contraindications to anticoagulation or any complications to anticoagulation or failure of anticoagulation to prevent the propagation of the clot from IVC to RA, RV and pulmonary vessels. Monitoring, these patients should be monitored with serial echoes to assess the resolution or progression of the clot. Coagulation profile should be monitored. Clinical signs of any embolism like stroke, pulmonary embolism or any limb ischemia should be considered. And serial monitoring of the concomitant other trauma-related injury should be looked at. So the take-home message from all this experience we had is early diagnosis or incorporation of point-of-care ultrasound in detection of such injuries, which usually go undetected until we go to a CT. So post-traumatic intracardiac thrombus is extremely rare and the management must be individualized according to the patient's bleeding risk, and we should always opt for a multidisciplinary approach. So anticoagulation is beneficial if the patient is hemodynamically stable and unless there is any active ongoing bleed. Surgical thrombectomy is one of the safest definitive option in trauma patient, and catheter-directed therapy may be considered if feasible, but at a risk of embolization of the clot. Thank you.
Thank you for the excellent presentation, Dr. Archana, Mehul, and our colleagues from radiology and trauma surgery. If there's any questions from the audience, we're happy to take. Yes, sir. So it depends upon the cause of thrombus, if it is provoked or unprovoked. Usually we say that if it is unprovoked, 3 to 6 months is what is generally recommended. So at 3 months, we would reassess, and if the patient, if everything is fine, then we usually stop at 3 months. If there is a cause where if in cases where the cause is cannot be treated, like say a malignancy patient on palliative therapy. If for those patients, it would be lifelong anticoagulation.
What's the explanation for thrombus and disappeared?
Sir, this patient was on anticoagulation, so and heart is a moving structure, so usually the chances of resolution of the clot with anticoagulation is higher. And even this patient was we had an INR of about 2 to 3 which was kept, and therefore the clot resolved. Anything else from the residents? Okay, thank you so much, sir. आपके टाइम है अभी